land, but physically distanced. I know that things are very stressful for many right now. We're really truly in unprecedented times, and just wanted to hope that everyone's doing well and staying safe out there. I'm so happy to have Dr. Adler join us today. It was really a wanted and requested topic about this brain donation and also tissue diagnoses and things like that that people have been requesting. And I managed to twist Dr. Adler's arm a little bit to, he has such a busy schedule and is just really made some time for us to ask him some really important questions that have been requested from the audience. So, so he's pretty well. Oh, I'm breaking up. Uh-oh. Am I? Can you hear me?
I can hear you just fine.
Yeah,
okay.
Now you're okay.
Okay. So without further ado, I just wanted to introduce Dr. Adler, who's at the Mayo Clinic. He is a MD, PhD. He has a background in pharmacology, he has a PhD in. He has many, many interests, and we'll be covering a number of them today, but I wanted to have him teach us a little bit about what got him interested in neurology in the first place, and then movement disorders, and maybe we can have a conversation that way, and I will try to, in the meantime, connect on my computer.
So Indu had asked me to speak today, which is certainly a pleasure. These are very difficult times for many of us, so I appreciate your wanting to hear about this topic and everything PMD Alliance is doing to try to make things easier for us in terms of things to do, things to help us get through these very tough times. So I thank the PMD Alliance and have worked with them for a number of years now, and I think they're doing a great job. So Indu, I think the first thing you wanted to know is why did I choose essentially the career path that I chose?
Yeah,
and,
maybe you could tell us a little bit about how that came about, and kind of,
sure.
You have such a rich background, including the PhD in pharmacology, so maybe you can kind of give us that background.
Sure. So I guess it starts with being a kid wanting to be a doctor. I always wanted to be a doctor. I had many family members that were doctors. So for me, it was always pretty much always the career path. Sometimes you get asked, what would you do if you weren't a doctor? I always say I would have been a sportscaster. I would love to be like Bob Costas. I mean, that to me would have been the other ultimate job. But short of being a sportscaster, being a doc is certainly was my absolute goal. And in terms of path and why I'm doing what I'm doing, so my father is a PhD pharmacologist, and that means he's a neuroscientist. He is interested in receptors and has had a very long career looking at narcotics and opiates, and I started working in his lab when I was in high school, so always had an interest in neuroscience, which was really fostered by him. But the most influential person for me was my grandfather. So my grandfather passed away at my age, I was 13, and he had Parkinson's disease. And he probably developed it, I don't know, maybe 5-6 years before that. A little bit hard for me to remember all the details in terms of it, but it certainly had a profound effect on my life in terms of watching what he went through. And as time went on through high school, I found myself only reading about, well, mainly reading about Parkinson's diseases. Any article that was in the newspaper, any piece of information I could get my hands on, Parkinson's was it for me. And so as my career developed, went to medical school, you sort of try to look for things that would replace that, and there was nothing that ever replaced it. For me, I was always most interested in the nervous system, interested in the brain, and for sure interested in PD. And going to medical school, we had the options, certainly being an MD or becoming a neuroscientist like my father, or at that time, we had the ability to go into a 6-year program, which gave me both, didn't give me, I think I earned an MD and a PhD. And I chose PhD in pharmacology because that pharmacology is the study of how drugs interact with the body. And so I had interest in trying to learn more about how to research the effects of medications, trying to understand what potentially could cause neurological disease. And again, just felt this pull through medical school to go into neurology. And I entered the field of movement disorders based, again, all on the fact of following the lead of my grandfather, which was I needed to find a way to better the lives of people with Parkinson's disease and find a cure to the disease. Ninth grade, I wrote an essay that was my retirement party essay. It was looking back on my career, and I retired because I had found the cure for Parkinson's disease. And unfortunately, I'm still sitting here working. So I'm sorry to say I don't have that cure for two reasons. One is to help you, and two is I'd be retired at this point. But I'm happy to discuss anything more into it in that respect. But that's really why I chose this. It's a very personal mission for me. Very gratifying mission as well, because as most of you know, so over the course of my 30-year career, we've had so many advances in the field of Parkinson's disease in terms of finding new medications, new treatments, better understanding of the disease, et cetera. So tremendously fulfilling career, just short of the fact that we have not found a cure or something to slow the disease down.
Wow, that's an amazing story. I had no idea. I'm actually learning so much about all the guests that I've had on this. It's really been kind of a silver lining, I think, of this moments that we're in right now, where we can pause a little bit, and many of us would be traveling the world and giving lectures all over, and it's just been really lovely to connect even through this medium. So I really appreciate that story, and thank you for sharing that. So you've really done a lot of different kinds of work. I was kind of going through your CV, and it's just really pretty fabulous. So I think you've, on the sort of road to trying to find a cure, you've really, been very dedicated and very productive, I think, in many, many aspects. So I'm going to ask you a few questions, just sort of hopping around some of those areas. And so first of all, I wanted to talk a little bit about some of the research that you've been doing to try to understand we will get to the brain donation topic, but I think even before that, maybe helping us to understand a little bit about biomarkers and what a biomarker is, and then also kind of some of the tissue sampling studies that you've been doing, and trying to help us understand a little bit about that, and maybe some patients may want to get involved in those sorts of studies, and you can guide them.
Biomarkers is short for the term biological marker. And so what it is it is a some sort of clinical finding, be it an exam finding, be it a fluid, so blood, spinal fluid, skin or other biopsy, an imaging marker such as an MRI or a CAT scan or a PET or DAT scan. So these are markers, and they are used for a couple of different purposes. Biomarkers can be used to identify people who have a disease. They can be used to differentiate people with different diseases, and they can potentially be used to follow the progression of the disease. And so probably it's certainly one of the hottest fields we have in Parkinson's, as well as many other neurologic disorders, is how can we find a way to develop a diagnostic test? And that would require some sort of biological marker. And how can we follow the progression of the disease such that we would be able to use a treatment and determine that the disease is actually being improved, being cured, being slowed down. So that's what we're using biomarkers for. That's what the term is used for.
And so what kind of studies are you doing in that area right now?
So there are lots of ongoing studies, both here at Mayo Clinic in Arizona. Part of my Arizona study of aging and neurodegenerative diseases, or AZSAND, and many other places in the country and the world into biomarkers. So some of them involve looking at blood and spinal fluid. So having a group of people who do or don't have Parkinson's disease and comparing blood markers, comparing spinal fluid markers. And the most interesting thing for me has been tissue biopsies. So looking at skin biopsies, colon biopsies, and biopsies of a gland here we call the submandibular gland. So as you know, this is the mandible, and right under the mandible sits a gland called the submandibular gland. So we've been doing studies in our group, but these are international studies. There was a really important study done by the Michael J. Fox Foundation. I'm one of the principal investigators of that, where we did blood, urine, saliva, the skin, submandibular gland, colon biopsies, spinal taps on a group of individuals that had Parkinson's disease for less than 5 years, Parkinson's disease for a number of years in between, then Parkinson's for over 10 years, and controls. And we've been looking for a protein. So number one is looking at these different tissues, but what are you looking for in the tissues? I'll take a step back. So as most of you probably know, in the brain of people with Parkinson's disease, there's something called Lewy bodies. That is the hallmark. The only way to make an absolute definitive diagnosis of PD is to do an autopsy and look at the tissue in the brain and see if there are Lewy bodies. And I know none of you want to have that diagnostic test, and I get that completely. But I tell you that because no matter what we do in you currently, I can't absolutely guarantee the diagnosis. The diagnosis requires looking at the brain tissue and looking for Lewy bodies. One day I expect, so Lewy bodies are made up of a protein called alpha-synuclein or synuclein. One day we will have a way of imaging that, so doing a PET scan or a DAT scan or some sort of image, so we could put you in a scanner, look for synuclein in the brain. We don't have that ability right now. So what we've been doing is been looking in the whole body and looking at other tissues. And one of the things we've found through the brain and body donation program that I work with, where we autopsy people with PD, is there is synuclein. There's synuclein in the submandibular gland, there's synuclein in the colon, there's synuclein in the skin. So PD is not a brain disease only. PD is a systemic disease. It involves almost all of your organs that we've looked at. And so we're looking, people in that PPM, in the S4 study are looking at markers such as synuclein in blood, urine, saliva, CSF, spinal fluid. And again, we're looking in various tissues to try to find a biopsy test to be able to make the diagnosis of Parkinson's disease. So those are the biomarkers that we've been most interested in. There are other markers in these different tissues and in these different fluids that are being looked at. But right now, the most promising biomarker is the synuclein protein, given the fact that it clumps up in the brain and we can find it in other tissues as well.
And from your research so far, have you gotten a sense of which of these fluids or tissues look the most promising for people to be tested maybe?
So we have been big proponents of the submandibular gland. That's the main research we had done, found that if I did biopsy, so one of the things that's important from the brain donation program, body donation program, is we've taken the research in the lab and we've taken it to the clinic. So we've done a number of biopsies on people of the submandibular gland. And when Dr. Beach, who is the head of neuropathology of our program, when he has stained the tissue, we find a high occurrence of synuclein in the submandibular gland of people with Parkinson's disease. It's very sensitive and it's very specific. It requires a needle going up into the submandibular gland, so there's some swelling, there can be some bleeding at that time. As part of further research we did with the FOSS Foundation and other groups around the world, skin biopsy seems to be also an effective, less side effects. So we can do what's called a punch biopsy. So there's a small punch, it's about 3 or 5 millimeters taken from the skin. We can now find this synuclein protein there. And even more exciting is there is new lab technique, I'll use the term RT-QuIC. And what they're doing is they can take the tissue from the skin or the submandibular gland, and they can put it in a test tube. And they can see how much synuclein is in there, both from skin and submandibular gland, and potentially be able to make the diagnosis that way. There is now a place here in Arizona that is doing commercial skin testing to try to make the diagnosis of Parkinson's disease. At this point in time, my own personal opinion is that if you have enough signs to suggest you have Parkinson's disease, you do not need a biopsy to confirm it. And why do I say that? I say that because it's not going to change your treatment. So all the diseases that currently look like Parkinson's disease, meaning that they have a tremor at rest, or there's slowness of movement, or there's trouble with walking, so the slowness of walking, almost all of those diseases or disorders have a decreased dopamine in the brain. They may or may not have synuclein present, but we treat them all in the same way. We use carbidopa, levodopa, we use ropinirole, we use pramipexole. And so doing a skin biopsy at this point in time in most situations is not something you need for clinical purposes. I think it's really, really important for research purposes. In a few types of patients, and I can get into that later if you have questions, a skin biopsy might be appropriate. But right now, I've not been recommending doing biopsies as part of routine clinical practice. I've been recommending it for research purposes.
Okay, that sounds good. And I think there's been 1 or 2 questions so far. One is, what's the function of the submandibular gland?
So the submandibular gland is one of the many salivary glands, meaning it produces saliva. So this gland here, the submandibular gland, and a gland here in the cheek called the parotid gland are the main glands that make saliva.
And then somebody else asked, does this finding also apply to PSP, to progressive supranuclear palsy?
Great question. So the answer would be no. And the reason it would be no is that PSP does not have synuclein clumping in the brain, and it does not have synuclein clumping in any of the other body tissues. The main protein that's abnormal in PSP is called tau. And we and others have interest in trying to find tau, not just in the brain, but in other tissues. But at this point, finding tau in the other tissues has not been as successful as finding synuclein in the other tissues. So this would not be something for PSP. If you wanted to determine if somebody that looked like Parkinson's had PSP versus whether they had PD, you could consider a biopsy. But again, there's no difference in treatment. So clinically, if somebody has all those features, I am not sure doing a biopsy is going to be helpful. I have some data which I may or may not show later to show that when I make the diagnosis of Parkinson's disease really early on, let's say in the first year or 2 of having the diagnosis, and then I follow the people over the years to autopsy, only 50 to 60% of those people, small study, but only about 50 to 60% have Parkinson's at the time of autopsy. And the most common thing that they didn't have, or they do have, is PSP. That's the most common problem for us, Dr. Subramanian and myself as clinicians, is they have PSP and not PD. However, those patients that I diagnosed as having PD early on, all were responding to carbidopa-levodopa. So people with PSP can respond to the same medicines that we use to treat PD. And so clinically, it's not as critical to make this differentiation as it is for research purposes, where it's really important to know what somebody has. So I hope that makes sense. Clinically, to you, the patient, not as important as for research purposes that we are doing.
Okay. So I think there's just been a few questions about trying to clarify some of those things. So just to take a step back, so I will try to make it a little bit, you know, simplified from my perspective. And then you can also—
I'm trying to simplify it as best I can, so I agree.
Yeah, so I think, so just for the people on the line here, so Parkinson's, when you see Parkinson's or Parkinsonism, patients have stiffness and slowness and sometimes tremor. Not all patients have to have tremor. And then a subset of those people, the majority of the people that look like that when they come to us end up having Parkinson's disease.
Correct.
But there are a number of other things that can look like that, including actually drugs. Sometimes medications can look like, you know, if you're on a medication that blocks dopamine receptors, sometimes the medication can cause it. So it's important to see a doctor and get an exam and go through the history and look at your medications list and take the time. And it's actually very helpful to see somebody who knows about movement disorders in this sort of setting, because we have a higher you know, ability to diagnose this accurately just from all of these things, because this is all we see day in and day out. And so, you know, we would urge you to try to get to a neurologist, and if possible, possibly if there's a question of your diagnosis, to see a doctor like Dr. Adler and I that have training in this. Sometimes though, in that umbrella of people that look like they're stiff and slow and shake, they sometimes have these other diagnoses, and some of them include the Parkinson's plus diagnoses, and these disorders include progressive supranuclear palsy. Another one is multiple system atrophy that there's a question on. Lewy body disease is also in these sort of category. And so these are Parkinson-like disorders that look different under the microscope when we cut the brain, or we look at these tissues from what you're saying. And this is helpful in some ways to understand, but we don't think at this point, given what we know about the biopsy technology and these other things, that we would do the skin biopsies to figure this out. It's probably much better to go see the right type of neurologist, a movement disorder specialist if possible, have them start treating you, and then follow you over time to check in and sort of use these research tools of the biopsies and things like that for research right now. Eventually, it might be that we can use these for clinical diagnoses, but it sounds like we're not quite there yet. Is that sort of your sense?
Yeah, I think the two things just to add to that. Number one, so you can imagine if all the research that we do into early Parkinson's disease, or even advanced Parkinson's disease, is assuming that Dr. Subramanian and I made the correct diagnosis. So if we enter you into a study and we enter 50 people who get placebo and 50 people who get the real drug, the assumption is all 100 people have Parkinson's disease. The advantage in a research study of using a biopsy would be to confirm that all 100 of those people, before they entered into the study, actually had this synuclein issue and actually likely had Parkinson's disease. So that's why it's important from a research standpoint. From a clinical standpoint, all 100 of those people we would treat in the same way, whether they did or did not have this synuclein in terms of clinical practice. So that's why it becomes important from a research standpoint. In advanced Parkinson's disease, where would the biopsy may be important clinically is the fact that deep brain stimulation surgery works well for people with Parkinson's disease. but does not work well for people who have these other diseases that Indu mentioned. So it doesn't work well in PSP. It doesn't work well at multiple system atrophy. So if we wanted to try to determine who should have DBS, potentially this would be a valuable tool. And I say potentially because we've not used it for that purpose. The last point was the dementia with Lewy bodies or Lewy body disease. So just like Dr. Subramanian said, there's an overarching term, Parkinsonism. It's like the term animals. You have dogs, cats, as Rachel has, giraffes. There's many kinds of animals. Parkinsonism has many kinds of diseases under its term. Lewy body disease is also an all-encompassing term. Lewy body disease just means that when we look at the brain tissue at autopsy, there are Lewy bodies there. People who have Parkinson's disease have the motor signs first, and at a later date, they may develop dementia. People with dementia with Lewy bodies have dementia first, and at a later date, they may develop motor signs of Parkinson's. So Lewy body disease covers both PD and dementia with Lewy bodies. There's no difference there. And we do find in the skin, in the submandibular gland, we can find this same synuclein protein in people with dementia with Lewy bodies.
Okay. There's one.
I hope that explains it a little bit better.
Yeah, no, that's perfect. So I think there's two other questions. One was if MSA looks like that, and also FT, frontotemporal dementia. So these are, again, all under the same Parkinsonism, and under that category, there's Parkinson's plus diagnoses, and all these letters, FTD, PSP, DLB, there's also corticobasal degeneration. All of these sort of fit under that category. So maybe you could just answer the FTD and the MSA.
FTD, no. FTD would not have alpha-synuclein. You wouldn't see synuclein protein clumping in FTD. It's a different neuropathology when Dr. Beach would look at the brain. In terms of MSA, MSA is a synuclein disease. So you do see clumping of synuclein. But in the brain of people with MSA, the synuclein is clumped in a different location. And the synuclein actually can look somewhat different. So the pathologist will see something different. In terms of skin or submandibular gland, I can say that we have not done research in MSA to see if we can find it in the skin or the submandibular gland. So right this minute, I would tell you that that's not something we could use it for. Again, it would not, for you as a patient, it would not change our treatment options though, and that's always where it becomes important.
Okay. There was one other question about, can you do a biopsy of the brain while you're doing DBS procedure?
Fabulous question, because we've talked to the neurosurgeons and whatnot about that. The answer is yes, you could take tissue at that time. The problem is that the tissue we would want to take for diagnosing PD is not where the needle goes in people with DBS. So it's in an area, we would need to biopsy an area called the substantia nigra, which is a much deeper area. You can't reach it, or you would not want to reach that with the needle. And it could do quite significant damage potentially if you were trying to biopsy that area in patients having DBS. But we've talked about biopsying tissue at the time and studying the tissue. I'm not aware of anybody who's actually done that because it's usually the cortex that you're going through, and that would not really be of great interest at this point in time.
Okay. I'm really proud of you guys. You guys are asking some questions like
Excellent.
that even our residents and medical students wouldn't be coming up with. That's awesome. We love this. Okay. So maybe we'll go on to the brain donation, and there's also already a couple questions on that. So I'll let you maybe talk about it and then we can take the questions. But what we had talked about maybe was, why should patients consider brain donation? What do we learn from brain donation? And how can it help the cause of Parkinson's patients in general?
If you're okay with it, I'm going to share, can I share my screen?
Of course, yeah.
Okay. I'm big on showing slides. So I'm going to show you a few slides. I think that it'll be pretty I'm going to do this quickly, and if you have questions, I'd love to hear the questions. Can you see it?
Yeah.
Okay, perfect.
Yeah. Now we can. Yeah.
So I'm going to talk a little bit about our program as well as another program that's available around the country. So our program is based in Sun City at Banner Sun Health Research Institute. Everybody who's part of it, we assess annually. We do a movement exam, a cognitive exam. We're looking for biomarkers, as I said, to both to predict PD. We're also interested in trying to predict who might develop dementia in PD. Let's see if I can advance. So oh, there we go. So I told you that not everybody who looks like they have PD actually does have PD. And this comes out of this is an important factor when it comes to future research. So if you look at we looked at 97 people who looked like they had PD. They had all the signs of Parkinson's disease. They responded to carbidopa, levodopa, yet we were only correct 82% of the time. You can see we're much more often correct as if the patient was seen after the first 5 years compared to the beginning 5 years. And again, this is small numbers, only 15 people, but we were only right 53% of the time. So the first advantage of being in a brain and body donation program is that you actually will get a guaranteed diagnosis. Now, you, the individual, will not get that, but the doctors will get that, and the family will get that. So there's an advantage to knowing what the actual disease was for your family. This shows you that we can look at the spread of alpha-synuclein. Remember, I told you where is the synuclein. And what we found is it starts in an area of the brain. It's actually up by the nose. It's called the olfactory bulb. And we see it there. Then we start to see it as it progresses in other areas of the brain stem. And eventually it spreads all throughout the brain. And this is important because what we have found is that if we look at brains of people who have no signs of Parkinson's disease, have no signs of dementia, we can still see this clumping in this area of the brain called the olfactory bulb. And we'll eventually see it in other organs, but not until we've seen it in the brain. So it's our belief that Parkinson's disease and dementia with Lewy bodies and these diseases may start up here in the nose and progress through the body. And so this is a new slide that I've found through colleagues of ours, Dr. Chen and Ritz. When somebody's born, we know that they have a genetic makeup, and about 15% of people have a gene that might cause Parkinson's disease. And then we see as one gets older and older, people start to develop certain symptoms, and we call these clinical biomarkers. People start to lose their sense of smell. Some people develop constipation. Some people develop something called REM sleep behavior disorder. They yell out, scream out, or act out dreams. And these seem to occur before, in Parkinson's patients, they develop tremor, slowness of movement, and rigidity. And there's a tremendous interest in trying to understand which part of the body might be first affected. I told you about the nose, skin or lungs may be a place, maybe even in the GI tract. Just to show you the group, this is not me only, this is a large group, and I want to show you Dr. Beach, who's the leader of the pack, and show you that in our group, we're looking every year at individuals. You have to live in Maricopa County. You have to live here at least 6 months out of the year. We're enrolling people with Parkinson's. We're enrolling people with REM sleep behavior disorder, that yelling out, screaming out, or acting out dreams. And I'll explain that again in a minute. And need to be willing to come in every year to be evaluated. And there's no charge for this. And here's the phone number if you're interested. And I think Indu was going to post this afterwards so people can get it. Now, unfortunately, that's only for people here in the Valley. But there's a second group, and I was told about this yesterday to highlight the Brain Support Network. This group does brain-only autopsies of people who live anywhere in the United States. You can call as a last minute, so if death is imminent, and here is their website. And so I would highlight them as well. So the value of being part of a brain or autopsy program: number one, the tissue is used to make the final diagnosis. Number two, anything that we learn about what causes Parkinson's disease requires tissue. So every advance that ever has been made in understanding that dopamine is lacking in people with Parkinson's disease, that synuclein clumping is one of the causes or believed to be a cause of Parkinson's disease, all of that has come from scientists around the world studying the tissue. And at least our brain bank that we believe is one of the best that we collect is then sent to scientists around the world to use it for these various different lab events or lab studies. And they apply to us for us to send tissue. They apply to the NIH. They apply to the Michael J. Foss Foundation for funding to study the tissue. So that's the second advantage. The third advantage is this idea of biomarkers. So we're trying to understand how the disease progresses over time. So we are looking at individuals early in Parkinson's. We're looking at people even before they have Parkinson's, and we're measuring all these things. We're measuring examination findings. We're measuring whether they have sleep disorders. We do smell testing every third year. So we're trying to look at those biomarkers to then predict who's going to go on to develop these different diseases, especially obviously Parkinson's disease. And eventually maybe predict who's going to progress and develop other signs, including dementia. So that's the value, I think, of being in these various different autopsy programs. And again, the other program that I just mentioned is very valuable. Tissue often sent to Mayo Clinic in Jacksonville, where they have an autopsy program there as well. And that tissue is sent to scientists around the world as well. So hopefully that's clear as why we do what we're doing and what we're trying to learn. And last but not least, I would tell you, eventually, the things we learn from that may inform us about what types of treatments should be utilized. So you may have heard about vaccines. You may have heard about gene therapy. Some of those are directed at stopping that protein synuclein from clumping. And if we can find a way through the brain and body donation program to study tissue and watch how that protein clumps in skin or in submandibular gland, we might be able to have a good marker to determine it would be effective in people with PD.
Okay.
I'm sure there are a lot of questions. I'm sure. I try to make it as simplified as possible. I do understand that it's hard to make it simple. I hope you understand it's hard to make it simplified.
Yeah, no, I think you're great. It's awesome. So I think one of the questions has been, when you say that they only a certain percentage ended up having Parkinson's, what did the other ones have as a question?
So the majority of those had PSP or progressive supranuclear palsy. There's some people who we autopsy and we don't find any clear-cut cause of PD. We don't know what caused this slowness of movement and the tremor or whatnot. Some people actually have Alzheimer's disease, and we have seen some people who have come to autopsy that we thought had Parkinson's disease. They had not had dementia right at the beginning, and yet at autopsy we find they had Alzheimer's disease. I will tell you that one of the interesting things, the majority of people that come to autopsy, as you can imagine, are in their 80s, 70s, and 80s. No brain is pristine. All of us, as we age, are having clumping of different proteins. All of us, as we age, have some changes that people with Alzheimer's disease might have, or there's a combination, we use the term heterogeneous. So when we look at the brains of a Parkinson's patient or an Alzheimer's patient, or even a control, you may see some of these different changes. So purity as we get older, there is no purity. We're all affected by changes and degeneration of the brain tissue. It's just how much degeneration there is and which locations. That's what tells what signs and symptoms we're going to have when we're alive.
Okay. There's also been a question or two about this, like alpha-synuclein versus synuclein, and just explaining what the difference is, and also if synuclein in general is an abnormal thing to have in your brain, and how, maybe just talk a little bit about that.
Sure. Synuclein is a normal protein that we have in our body. It's not abnormal in its, what I would use the term, native form. So it's in normal form, it is a normal protein to have. But people with Parkinson's disease and some of these other diseases that we've talked about, one of the forms of synuclein is alpha-synuclein. There are other forms of that protein as well. And that alpha-synuclein can get phosphorylated, meaning that it can be changed in the brain and other tissues to have a phosphorus added to it. And that causes it to clump. So the change in the synuclein and the clumping of synuclein is what's abnormal. The protein itself can be completely normal. And that's one of the things, therefore, we have to be careful about in treatment. You wouldn't want to wipe out the entire body of this protein synuclein, because it is an important protein. It does play regular, normal roles in our body. But it's, why does it become abnormal? Why does it become phosphorylated? Why does it clump up? That's where we're trying to find ways to treat it. We're trying to treat it by stopping it from getting phosphorylated, by stopping it from clumping.
Okay, that sounds good. Now, there's been a lot of questions about, specific ways to get brains donated in different parts of, the country. And I know that that's a very specific issue with individual cities and locations. So we won't get into the specifics of those. And, I think that the PMD Alliance is going to look into Tucson, which I think is, where they're located and stuff, and maybe post some things. But I don't think we can answer every little place. But I think it is important to try to find out the specifics in your own community and connect with those people. There's also been a few resources posted. The Oregon OHSU gang resources were posted by someone here, and then also the one with the Jacksonville team, the Brain Support Network is also posted here, which you had mentioned, I think, as well, Chuck. So I think we probably won't get into the specifics of those questions. There's one question: is clumping related to folding? The folding project at Stanford is a distributed computing project that everyone can participate in. Do you know too much about I don't know too much about the Stanford.
No, I use the term clumping because there are issues with folding and how the synuclein changes. So absolutely correct. Folding plays a role in the clumping or aggregation. I don't know about the Stanford program, though. I'm sorry.
It might be good even, I might have our local, or maybe Dr. Beach might be, he's the neuropathologist that you work with. Maybe we could have a neuropathologist on just showing a few slides to make it a little bit more clear what they're seeing on under the microscope. And I love Dr. Vinters, who works with me, and it sounds like you're a big fan of your own neuropathologist. I mean, I think they're sort of the unspoken quiet heroes back in behind the lab there, and you know, such an important group of doctors that are, you know, just really working hard to help us understand. You know, we take care of patients for many, many years, and then, you know, the brains end up with these folks, and they take such good care and do such good work to help us understand, you know, the ultimate diagnoses. And so I think it may be helpful to the group here. Maybe we'll have that as a talk coming up. So I want to just also speak about one other thing, because I think you have this rich experience, Chuck. You are an officer on the Movement Disorders Society, and we talked a little bit about the fact that on a previous one of these with, I think it was Dr. Oken, one of the issues that got highlighted, and I think we're highlighting it again a little bit here, is that there's really not enough neurologists that know about Parkinson's in the country, and many of our patients are actually being seen by and managed in the long term by non-neurologists, let alone being able to even access a movement disorder trained doctor. And this has really been something that I think, you know, in the book Ending Parkinson's Disease, they're talking about advocacy and how patients can help, you know, advocate for these things. Could you speak a little bit about your role, and maybe a little bit about the Movement Disorder Society and your role, and how you think that we can, you know, help patients and with this issue, and ultimately ourselves with, you know, training more doctors that are like us?
So the International Parkinson and Movement Disorder Society has been around for 30 years now. And that society has as its mission to essentially to educate people around the world about Parkinson's disease and other movement disorders. I served as the chair of education for 2 years, and now serve as secretary-elect and will be secretary. So that's a 4-year term as an officer. And my goal and the goal of the MDS has been to promote education. When I first started, it was to promote education of physicians. Now there's even an educational arm to promote education to patients as well. So you can go to the Movement Disorders website, movementdisorders.org website, and get some patient information if you're interested. But the biggest issue is to find a way, not just to train neurologists to become Parkinson's specialists like we are, because there's going to be a limit as to how many docs are going to want to go into movement disorders. We know that, we understand that, we are trying to promote it. The MDS we hold an annual meeting for residents, so that we bring residents at no or decreased charge to them to a weekend where we educate them on Parkinson's and other movement disorders, trying to excite them about it. That's also done in other countries. So the goal is to excite neurology residents to go into our field. I will tell you, one of the reasons why they don't go into our field is they don't have as much exposure to us as they do to other specialties. As you probably know, when a neurologist trains, we do 10 to 12 to 14 months in the hospital. And luckily, we don't send many PD patients to the hospital. They do stroke rotations, they do headache rotations, they do rotations in which they might make a little bit more money. So they do EMGs and they do EEGs and they do things like that. And that seems to attract a lot of young doctors. And so what we've tried to do with the MDS is we have made the society free of charge to all students and residents. Again, we're promoting education to students and residents with the idea of exciting them to go into our field. The second aspect that we're doing with the MDS is we are educating non-movement disorder doctors. I have spent 30 years putting on a program here at Mayo Clinic where we specifically try to educate general neurologists, internists, family practitioners. Same thing with the MDS. We have programs around the world trying to educate general neurologists, internists, family practitioners on how to treat PD. Some of them have actually gotten really good at it, which we're really fortunate. Movement disorder doctors tend to be located in big cities. It is rare to find a movement disorder specialist in a rural town. That's mainly because they won't have enough patients. So really the concentration of patients, you sort of have to be the center of the, you have to be a hub and expect patients to come in. I will say, Indu, you asked me what might be one of the silver linings right now of the whole COVID crisis. And one of the silver linings might be the increase in telemedicine, the increase of doctors seeing patients via Zoom, via virtual visits. This, if it continues, and if the states allow us to cross borders, which they did not allow us before. We used to have to get a license in every state where we saw patients, so that's one. And two, if the insurance companies will reimburse. So if you ask about advocacy, I would advocate really hard to get states and insurance companies to allow us to do these virtual visits. Because while it's important that patients have local doctors in case of various different actions that they might need, I can tell you I've spent the last 2 months by and large doing virtual visits, both new patients as well as follow-up patients, with patients from Hawaii, Idaho. I have patients in Utah, Southern California, Nevada, et cetera, et cetera. Mayo Clinic is a huge draw, as you know, to patients around the world. And we have the ability now to see patients that just can't travel to see us. So my hope is that the Movement Disorder Society, the movement disorder doctors will be embraced to allow our expertise to get out there to people who cannot travel to us. But I think it's really, really critical that as Parkinson's progresses, being able to see a movement disorder specialist really can improve one's care. I think early on may be important, certainly important to understand all the different options that one has, but certainly as the disease progresses, understanding the disease and getting into a specialist becomes more and more important. I hope that answers that question for you.
Yeah, definitely helpful. So there's a question about how long in the fellowship is, usually about 2 years. And
so some people believe in 2 years. Some people like me believe in 1 year. I did a 1-year fellowship, as do all my fellows. They do a 1-year fellowship. So I would say 1 or 2 years. And I can give reasons for 1 and 2 years, but I'm a personal believer in 1 year. We all train forever, and so I think that 1 year of training, one can do really a lot of good, gain a tremendous amount of expertise in movement disorders.
okay, that sounds good. I'm glad you spoke up. And then somebody said, you should have the students talk to us. Parkinson's people are lovely and could convince them to specialize. And I agree. I think the more we connect patients to medical students who can be impacted by them and make a change early on, as some of the stories you've heard about people who've chosen movement disorders have been inspired through their medical school if they didn't have a relative with it or whatever. So I think sometimes it's just meeting the right patient at the right time to inspire a career-long journey. So
I agree.
Yep.
Now, a lot of medical students do not need to do a full month of neurology training. So, but those who pick, or those who want to do some extra, we have medical students in clinic all the time who are training with us, so they do get a chance to see patients. I agree with you wholeheartedly that when you meet patients, this is with PD, but this is with many different diseases, it totally changes your perspective. The Fox, I don't know, I don't think PMD Alliance is doing much in this regard, and if you are, I apologize. The Fox Foundation, and there's something called the SAFRA, there's funding through a SAFRA fellowship, is really trying very hard to bring that to students and young physicians. So there are groups that are working on trying to do that. Again, the MDS is trying to do that internationally, but I could not agree more.
Okay. A couple of questions here. One is, one is about, so is the issue with getting brains looked at, is it a financial one? Do they need more funding? Is that what's standing in the way? And a second question is about whole body autopsies and what the advantage is to that. Maybe you could speak to those.
I'm going to do the second one first, if that's okay with you.
Yep.
So what's the advantage of whole body autopsies? So we started doing whole body autopsies in 2005. Before that, we were just a brain donation program. If you only study the brain, we never would have known that synuclein clumped in the submandibular gland, that it clumps in skin and heart and colon, etc. And so the whole field of tissue biopsies was born out of the whole body autopsy. Again, Parkinson's disease is not a brain-only disease. It is a whole body. It's a multi-organ disease. And we learned that through whole body autopsies. And we have people who have asked us for tissue on the GI tract. So we've sent colon tissue to Emory University and other places to study that. And this whole idea that Parkinson's doesn't start in the brain, but it may start in the nose or it may start in the GI tract, all came out of the whole body autopsy program. So I hope that makes sense.
Yep.
Money is always important. So we have financial support from the Michael J. Fox Foundation, from the National Institute of Health, so the NIH, from the state of Arizona, from donations, specifically at Mayo. I have people who have helped fund my time as part of the Brain and Body Donation Program. I don't know about the Brain Support Network, so I'm sure Robin will put something on there. But finances is always a very critical thing, but I would tell you that's not stopping what we're doing. And in terms of scientists around the world utilizing the tissue, all of that is dependent on them getting grants to be able to use the tissue. So that is a funding issue.
Okay.
I hope that answers that question.
So I think we're almost at the top of the hour here. Maybe we could just have you say a few lines in closing, and maybe, something inspirational, even from an advocacy or whatever.
Maybe inspirational? So I would close by saying that in the past 30 years of my career, we have made a tremendous amount of advances, which has made it really, really gratifying to me. We can treat patients better than we could 30 years ago. We have decent, I won't use the word good, I'll use the word decent treatment to help symptoms, including surgical treatments now, which certainly we didn't have when I first started, but we've got a really, really long way to go. I am completely inspired by patients on an everyday basis, and I am completely inspired and excited about the research that our group is doing, but that lots of groups are doing around the world. There is a lot going into this idea of looking for a biomarker. The earlier we can make the diagnosis, the better chance we have to treat it. I will tell you, we didn't talk about this before, but the fact is that by the time we make the diagnosis, there's already a lot of degeneration in the brain. If I could make the diagnosis 20 years before you had rest tremor and slowness, I might have been able to treat it better. And those are things we're going to learn, continue to learn from the autopsy programs, but also continue to learn from various other studies that we're doing. So I'm tremendously excited about the future. I just can't tell you what the timeline of that future is.
Well, Well, thank you so much, Chuck. I mean, you're so inspirational yourself, and there's about
Thanks.
7,000 comments here just talking about how inspirational you are. People have said, thank you for your time, wonderful presentation, excellent presentation, great discussion, keep up the great work, wonderful program, thanks to both of us. Please have a pathologist in the future. They want the pathologist, so either Dr. Beach, we get to argue about if it should be Dr. Beach or Dr. Winters. And yes, everyone has just been so thrilled to have you on, and really, thank you for your leadership, and they want you back. Apparently it was too fast, and bring him back.
Always
So
too fast.
we might have to sign you back up, unfortunately, but yes, we loved having you, and I mean, an inspirational, your granddad, it was your granddad, right? You said?
Yep.
Yeah, would be very proud of you for all
Thank
you've
you.
done. And who you are, and getting to know you, it's been just lovely, and you've been an inspiration to me in the field, and have followed, hope to follow your path in some way. So
You're doing a great job. That's all I can say.
thank you. Well, we will be happy to partner with more patient education, because I think it's so important, and we are clearly trying to make some good things happen here during this crisis. But we hope that people will continue to try to donate their brains if they can, stay involved in research, advocate for more funding, advocate for more training for doctors, I think, across the country and across the world. And thank you again for your time, Chuck. I really appreciate it. And we will try to bring you a pathologist soon. So back to you, Rebecca, for our wave off.
Yes. And, Dr. Adler, you were wonderful, as everybody has said. And I don't know if any of you know this or whatever, but Dr. Subramanian has been, I mean, she's volunteering her time these last, 3 months has it been, not only just hosting all the time, but she's helped us get these amazing speakers like Dr. Adler. So Dr. Subramanian, thank you you have just made this possible. And I hopefully speak for our audience to say, these have been wonderful. We do have another one coming up on Monday with Benzie Kluger. Hopefully I'm saying that correctly, which I'm really excited about. And as always, we have our support groups on Tuesdays, Thursdays, and Fridays. So please check out our website, and let's do our wave. And just thank you, Dr. Adler, and thank you all for joining us, and we'll see you on Monday.
Take care,
Bye.
everybody. Stay healthy.
Thank you.